because you know you're going to get the same standard of care anywhere you go in any institute or hospital. Yeah? So that's the importance of standardization. Okay. Small changes, big impact will show. So I'm going to go through this quickly once again to be mindful of time. I think the introduction is important to get you situated, and then I'm going to go through some examples. So what's global health research? That's what I do. I'll just quickly say global health started during the colonies. Okay, when India was colonized, it was colonized by a few countries, but namely Britain. And so when Britain sent their representatives to India to represent Britain, they had to care for them. And that was global health. So that was the beginning of global health. It was to safeguard and to keep healthy the representatives from the colonizing country, okay? All around the world, not just India, all over the world. The second global health was then, obviously in more recent times, was where privileged countries were helping underprivileged countries. So it was very patronizing, okay? We're helping you. That ended. Well, it should have ended. It's almost ended. Currently, global health is a partnership. And we realized that notably during COVID. So meaning that if we don't all globally work towards healthy population, we all suffer. So that's the new global health, which is a partnership. It's no longer patronizing because we realize, as a privileged country, that we need everybody to be healthy for us to remain healthy too. So it's a partnership, okay? So that's what I do. So I work in Costa Rica with indigenous populations in the rainforest. It's a great opportunity, a lot of fun. And what we do there, I love showing this picture because it shows me here in San Vito, in little villages, communities in San Vito in the rainforest, and I'm going out collecting data. So for me as a data scientist who works on computers all day, every day, it's kind of nice to go out and actually have to collect data. So that where I'm collecting data was an 1.5-hour walk from the nearest road. And some of the villages we went to were 3 hours. Okay, so what are we doing? We're developing what's called M-Health. And so that's where the idea of access to care comes in. So believe it or not, everybody in those communities have a cell phone. What? Right? So there's no cell service in those villages. They don't have, well, the schools have tablets, but they all have a cell phone. So they actually walk from their village every day down to the edge of the community where the indigenous communities are a region, and then they go to the edge of it where there's cell service, and then they get connectivity for their phone. They do that every day or every other day, and that's how they use their phones. There's also a high proportion of illiteracy, as you can imagine. They still use their phones because they just learn by imagery and by routine on how to use it. So what we're doing is we're developing software where we couple together preservation of their way of life, so their culture. So we're working with language and with medicinal plants. It's called phytotherapy. And by recording and helping them teach phytotherapy or medicinal plants and language, we're engaging them in M-Health. And then inevitably, we then have a platform that we can share information about diabetes, information about mental health. And so we're working with the government in order to do this so that they have a means to have access to care, a greater access to care. What's another thing we can do? So now I'm just zipping along into what we do. So ultrasound is a very non-invasive, portable, and can be portable form of medical imaging. So if you haven't had an ultrasound done in your life so far, good for you. That's good, that's a good thing. But taking ultrasounds, the most common one that everyone's gonna think of is if you get an ultrasound if you're pregnant, right? You're gonna get a pregnancy ultrasound to make sure the fetus is healthy. That's an example of ultrasound. What we're using it for, this first example is we use it in a rare disease. So there you go. I'm working with a rare disease, so not cost effective. It's called hemophilia, which is a bleeding disorder, which you may have heard, from all the Russian royalty originally. But hemophilia affects a very small portion of the population. It affects mostly men, males, very few females. Because of the way it's inherited, it's challenging. It would be poor family planning for a female to get hemophilia because both parents would have to have hemophilia. So, you'd kind of think if you both have hemophilia, you're not going to have children. So, but it happens, and so some females have hemophilia. And so what we're doing, unfortunately, what happens is, when you guys fall, I'm assuming none of you have hemophilia. If you fall when you're, walking to go shopping, you hit your knee, and the next day it's like, ooh, my knee's sore, right? And it's a little harder to bend. Most probably what happened is you bruised it. But bruising, as you know, is a form of bleeding, right? It's very small hemorrhaging. But the thing is, as soon as you hemorrhaged into the joint space of your knee, you stopped hemorrhaging because you don't have hemophilia. So you can clot. But in hemophilia, you keep bleeding. So then what happens is all of their joints, where, obviously the ones that are susceptible, knee, elbow, ankle, they bleed into them enough that it damages the joints permanently and results in either joint replacement requirement, but they bleed, so surgery is very difficult, or it just results in, unfortunately, not being able to get around, being in pain all the time. It's very painful. So, using ultrasound, what we did is we were thinking of trying to what we call empower patients, and that means provide them with maybe ultrasound to go home, have the ultrasound machine at their house, so that they can check to see if, when they have pain in their knee, they can check to see if there's bleeding, and if there is, then they treat. So you might be thinking, why don't they treat all the time? So that's another discussion. It's just because factor, which is required, factor 8, factor 9, for treatment is unbelievably expensive, like just ridiculously expensive, and that's the reason I don't know the proportion in India, but I'm certain there's a large proportion of hemophiliacs in India that go untreated, and so they suffer the problems that I'm addressing today, because it's just too expensive. It's just too expensive. Okay, so if they were able to go home with an ultrasound device and check to see if they have bleeding, they would not have to travel to what's called a hemophilia treatment center in order to find out whether or not they need to inject themselves with factor, okay? So it's access to care. It's improving access to care. That's what it's for. We developed an algorithm. So you're a non-machine learning group, so I'm going to take pity on you guys. So we'll just say, using ultrasound imaging technology, we developed a machine learning algorithm that provides the ability to assess a joint for fluid in the joint. So it's called synovial recess distension. And essentially, it's telling us if there's bleeding, okay? And patients can do it themselves, all right? So we were successful. I'm not going to go through the application flow because, as you say, you're not a machine learning group. But suffice to say, it's not an easy thing to do, right? To train an algorithm to identify whether or not there's bleeding in the knee, and to have a patient do it, because inevitably, think of it, if you're an untrained professional, how are you going to know how to put your, the transducer on your knee, right? So our software, captures the right image at the right time. Okay, so it's semi-automated because you still have to have the patient move the transducer. Anyway, so that's, in a nutshell, that's our software. It's currently being commercialized by Novo Nordisk. Novo Nordisk is one of the biggest biggest companies that produces factor for hemophilia. Okay, so then I'm going to go in now into start talking about the problems or the challenges of AI. So remember store, compute, learn? So if you don't have enough data, you can't do machine learning. So in this case, our algorithm works with adult knees, not children. So who would you want to treat more effectively, adults or children, if you had to make the choice? Obviously, you want to treat everybody. But if you had to make the choice, who would you treat first? Children or adults? Well, yeah, because it's not that we don't like adults. We're all adults. We like ourselves. It's just that adults, it's a little late. You know, there's already damage to the knee. You're already suffering. You already have pain. And it's kind of too late. I'm not saying give up, but it's a little bit, right? But in children, they don't have damage to their knee yet. So if you treat them at the right time, then you avoid damage, and then they don't become adults like us. So that's why it's important. But unfortunately, we don't have that data. As you can imagine, pediatric data is even harder to get because there's less of it, because it's children. And then children, every year, what do children do every year from the day they're born until they're adults? They grow. How annoying is that? Because it changes. Every year they look different. They're bigger, their joints are bigger, you know, their developmental stages. So it's extremely difficult to get the data necessary to train the algorithm. So what I'm showing you today is a project that my postdoc, Nushin, worked on, and other students, where what we're doing is we're using synthetic data. So we're using machine learning in order to generate fake data, which we then in turn use to train the previous algorithm to recognize bleeding in children. So there's an application of AI that's kind of cool, that you can actually make fake data that's helpful. Now don't think it's perfect, it's not. It's not perfect, and I could go into the stats, but I won't, I'll take pity on you. The best you're gonna get is maybe about, in our experience, about 8 to 12% increase in accuracy using fake data. Okay, that's what we got. It's not 100%. You can't do it. Think of it. It makes sense, right? That if it was all fake, well, what are you training on, right? And it's also not something that you're going to want to retrain with real data eventually, right, when you get it. But it's kind of cool. It works. So using synthetic data, these are the 3 age groups that we work in, 0 to 8, 9 to 13, and 14 to 18, because developmentally, those are kind of 3 big categories in children. And what you're seeing here on the left are what's called suprapatellar longitudinal view of the knee using ultrasound, okay? And on the right is what you call a heat map, and that is where it shows where the algorithm paid attention to make the decision. And so what we're showing is it's looking in the right spot, okay? Because this is your patella, this is your femur, quadriceps tendon, and right here would be, if it was, there was bleeding, you would identify bleeding. So you can just tell from the map that it's looking in the right spot. Okay, so I'm just confirming for you that it works. Okay, another example is thyroid cancer. Okay, so it's a problem everywhere, including India. You can use ultrasound in order to assess whether there are lesions, cancerous lesions in your thyroid. It's measured in our world as TIRADS. And so you have to go to, you know, I think in India you go to the hospital for ultrasound, or do you have clinics? I can't remember. Like, do you have small clinics that do ultrasound? I don't know. But in any case, you have to go to somewhere to get it done. So if you live way out in a rural community, there's no way you're going to be driving in to get an ultrasound done. So what we work in Costa Rica is we work with the healthcare team who go out to indigenous communities in order to do the assessment. And so what we've done is we're trying to embed into, your phone or into a tablet software that enables detection of thyroid lesions for the healthcare provider on the spot right there in the community, which provides them a little kind of, oh, wow, I should pay more attention, I need to do more testing, more whatever, as opposed to, when they're doing it, and they just wait until they bring the information back, right, to the radiologist, right? it just provides more care, more access to care yet again. It also means that an untrained, relatively untrained professional could also do it. So then you don't have to have a trained professional go out into the rainforest. You could have a less trained professional go out into the rainforest. Anyway, so you get it. So it increases access to care. We're good? Like, you guys don't have to run anywhere? Okay, I'm just checking. Just checking. I'll go a little quicker. So I like to show this one. Once again, it's too small, so I'll explain to you. So what it is what causes or what contributes to cancer, all the cancers, right? So the study of cancer. So if I were to ask you guys, what's the most important factor that contributes to cancer, what would you say it is? Just blurt it out. What do you think it is? What causes cancer most often? Lifestyle? Wow, good for you, buddy. That's the right answer. Very rare I get that answer. What's that? Your? Global warming. Okay, so you guys are kind of hitting it right on there. So usually people say genetics, right? People say, family history, right? So if mom had it or dad had it or somebody had it, that's what leads to your cancer. But actually that part of it is very small. You see here it says genes here. Was that me? Okay. Oh, there we go. Thank you. It was just a little interlude. So the gene section of it is actually a very small component of it. It's 5 to 10%. What? 5 to 10%? So all this worry about it, mom had it, dad had it, whatever. It is a very important component. Don't get me wrong, but it's quite small. So lifestyle is absolutely the right answer. When you look at environment, it's 90 to 95% is environment. And what are the big ones? What are the big ones? Diet, over a third. Tobacco, like smoking, non-smoking, another third. Infections, 15 to 20%. Just that alone, alcohol, 6%. Just that alone is a huge component on being able to deal with cancer. So the reason I bring that up is so for you research community or healthcare practitioners, just remember, wow, the impact you can have if you were to actually change lifestyle in your patients. It's mind-boggling, isn't it? So when we do research, and I tell my students this all the time, or prospective graduate students, I'm not saying don't do research in identifying genetic components of cancer. No, that's very noble. But don't forget, wow, you can do a lot of other interventions that can help that don't involve any of that. Nutrition. Like, wow, just dealing with nutrition is so impactful on so many levels. Not only cancer, but then type 2 diabetes. It's huge, right? So that's the reason global health should really be focusing on most impact. And so that's going to be, I think AI is going to be a fantastic tool to address those areas which we haven't been successful to date, right? Because no one listens to mom and dad, right? Who here listen to their mom and dad all the time religiously, right? Nobody does, right? Do you listen to your friends? Yeah, you're probably, susceptible to listening to your friends. Do you listen to your professors? Absolutely not, right? So who do you think you may actually listen to? Yeah, you're probably going to be listening to ChatGPT more than you think. So if you can train the appropriate agent to give education about lifestyle changes, about type 2 diabetes, mental health. Wow, big one on mental health. Everybody here is happy to say, oh yeah, I always eat too much, and I eat too much sugar, and I don't exercise enough. And people are comfortable saying that, right? Oh, I'm going to get to it. I'm getting to it. I will, I promise, But who here is happy to talk about anxiety, depression? Nobody. Nobody is going to tell their friends, oh, by the way, I'm depressed. You know, I'm clinically depressed and I'm medicated. Who says that? Nobody says that. So think of it, dealing with it through your phone is actually kind of nice because you don't necessarily have to share with the people you don't want to share with. You know, you don't want to sit in front of a psychiatrist who, let's say you're a woman, and you're sitting in front of a typical older male psychiatrist. You know, are you going to be really comfortable talking about your problems? Maybe not, right? And so maybe AI, that's a solution. Okay. Oh, whoops, forgot to, I'll just quickly here. So where are we at for cancers? Women, it's breast cancer in both countries, Canada and India, yeah, so LMICs. Men, it's prostate cancer, and for LMICs, it's lung cancer. Oh, I forgot for women, actually, cervical cancer is pretty big here, okay? Because you're not testing, which is a shame. But it is also a problem here. And the worst cancer is lung cancer across the globe, okay? So that's just everywhere because it's terrible. Once you get lung cancer, you know, it's not a good thing. Okay, so that's I'm just showing you. So what are we doing in Costa Rica? We're looking to put AI into breast cancer screening. Breast cancer screening around the world typically is every 2 years. I've heard in India it's a paid thing. You have to pay to be screened, is that right? So that's unfortunate because then not everybody's going to get screened. Oops. But in Costa Rica, they actually screen every year, and that was a political decision. They don't need to. It's every 2 years. And so what we do here, that's a mammography of a breast, and it's looking for a lesion in the breast, and we can automate that using AI, right? Nothing new there. That's not like, oh, wow. No, it's been years we can do that. Has it been adopted? Not really, right? And why is that? It comes back to how accurate is it? Let's say it's 92% accurate. So that means it's only 92% accurate to the best radiologist, right? So once again, remember I said you don't always get the best radiologist. So getting AI at 92% all the time, everywhere in the world, that's already pretty good. But how about if you're in India and you don't have access to a radiologist, or you don't get screening because it's too expensive? Well then, a 92% accurate AI model is actually way better than nothing. So if we can introduce, that's what we're doing in Costa Rica, is we're introducing an AI stream so that as soon as it gets scanned, an answer is there, and then if there's a suspected lesion, then it goes to the radiologist for confirmation. So it's a triage, right? So in India, that's not going to solve the problem because you don't get screening. So the only way it would work in India is you'd have to reduce the cost completely so that it would be affordable for women to go and get screened every 2 years, right? But to do that would be AI once again, right? So then you cut out the cost, let's say, of the radiologist, or reduce the cost of the radiologist. Where you'd have to reduce the cost now is the mammogram. I have no solution there for you, but that would be the target, right, is to reduce the cost of the mammogram. Okay, so let's just see. You're going to say then, once again, you're skeptical about AI. So this shows out of 150 mammograms assessed, the general radiologist, so the radiologist trained on all modalities, got 95 out of 150 right. That's the general radiologist. Some people are like, what? Shouldn't they get them all right, right? They don't. It's not an easy task. The general radiologist with AI improved. So they used it as a tool, and they got 120 right out of 150. The breast radiologist, someone trained on breast radiology, that's all they do, they got 123 right out of 150, right out of the gate. And then with AI, they got 140 out of 150. Now that's starting to sound a little bit better, right? 140 out of 150, that's what you'd expect, right? AI on its own is 128 out of 150. It does kind of make you think. I'm not saying, this clearly shows that I'm not suggesting we should remove the radiologist. Clearly not, because it's way better with the radiologist. But if you don't have access to the radiologist, or you don't have access to a trained breast radiologist, then AI is not bad. And so that's the idea behind global health, okay? The implementation of AI, accepting the limitations. But if you can, then yes, of course, keep the radiologist. Okay, so now I'm going to switch gears really quick, just for fun, because it's impactful in India as well. Infections is a huge problem in all LMICs. Low, middle income countries, infections are huge. Okay, I'm just going to point it out right away. You guys are bare feet all the time. Oh, so am I, now that I'm in India. When I visit the temples, I have to take my shoes off. So you guys take your shoes off all the time, and you wander around without your shoes on. So you can imagine infections in your feet is not going to be uncommon. It happens, right? Clearly it happens, right? What do infections do? Unfortunately, and I'm not saying infections in your feet, but infections do contribute 15 to 20% to cancer. They also contribute to, obviously, infection that you have to deal with, right? Fevers and all that. So infection's a big deal, and what you're maybe not even thinking of is, and that's my student that put those in just for fun, dentistry. You all brush your teeth, I hope. I'm not even going to ask. I'm just going to assume everybody brushes their teeth. So what if you don't have good oral health care? What happens? You can get infections. And those infections can actually lead to worsening overall health for you. Cardiac involvement as well. So where are you guys at for dentistry? 5 to 28 dentists per 100,000 people is the average for low middle income countries, and you guys are right in there. So you have about 20 dentists per 100,000 people. The biggest problem, of course, is access to those dentists, because dentists don't want to live in rural communities. They want to live in cities because they earn a good salary, right? So then you have to go into the big cities to get dental care. So then you're thinking, okay, why is this guy talking about dentistry for AI? Well, think of it. What's one of the biggest problems? Okay, we just did that. What's the biggest problems when you're at school? Who here is still a student or a trainee? You guys are all faculty, staff? Students. Yeah. So who's a student or a trainee? Yeah, okay. I was gonna say, what? Okay. So when you're evaluated on a task, especially if it's something that you have to perform, right? An OSCE or something like that, that you're being evaluated by a professor. And you know that after the exam, you're going to talk to your friend and say, who are you evaluated by? And you'll say, oh, Mrs. No. And then you say, well, I got this mark, and you got a better mark, and we did the same thing. How's that fair? That's all the time, isn't it? Okay, so what we're doing, in dentistry, they practice, drilling teeth, right? They call them preparations. And of course, you have to be evaluated. So who evaluates? The professors. And this is a huge problem, right? Because the professors, A, don't want to do it, and B, they are just really not reliable. Like, we tested it, not reliable. But if we use AI, and that's what we're doing, so we're scanning the preparation, right? You scan it, and then you feed it into our algorithm. It assesses it and gives the score. So you're going to say, oh, yeah, but it makes mistakes. Here we go again. Yes, it does make mistakes, but you students, what would you prefer? Would you prefer your mark with knowing that there's an error, right? So just like when you step on a scale in the morning to see how heavy you are, you know that that's your weight plus or minus, right? Well, let's say you got your score plus or minus. Would you be happy with that, or would you like to go with the we don't know who's going to evaluate us problem? Well, yeah, everybody wants to be evaluated fairly. So just because there's error doesn't mean it's not fair. Make sense? And so then that's where AI can help. And then, of course, cheaper education for dentistry, more dentists, not solves your problem, but improves dentistry. There we go. I'm not going to do the the plates, just for time. Okay, sustainability. So it was just another project in dentistry. You can imagine there's many projects we can do with AI. Sustainability is always important. Of course, I'm going to go through it very quickly. The one I want to just talk on very, very quickly is bias in AI is huge. So bias means the data you train on is going to generalize well to the same data, correct? Okay. What happens is who is training the algorithms is not aware of the bias and therefore results in a biased algorithm. So I'm going to give you a perfect example, the one I developed. So hemophilia is almost exclusively male. So is my algorithm going to work well on the few females that have hemophilia? No, right? Because I trained on male, right? So should I care? Do I care if my algorithm works well on females? Yes, I should, because that's not fair to put out an algorithm that doesn't work well in females but works well in males. That's not fair. So I would not do that. So what we had to do was find a way to train equally on males and females and have an algorithm that works equally on males and females, and we did that. And if you're interested in finding out how we did that, I can explain that, but it's a technical thing. This is an example. I'm going to show you again. This is a suprapatellar longitudinal view of ultrasound. Can you tell that this is a knee? Absolutely not, right? Unless you're an ultrasonographer, you're not going to know, or a radiologist, you're not going to know. Now I'm going to ask you, even better, can you tell that this is a male or a female knee? So even ultrasonographers actually they can't, tell that it's a male or female knee. When we trained an algorithm to detect whether it was a male or female, we got 95% accuracy. So that means AI was capable of telling whether that image was male or female based to 95% accuracy. So what this shows is that when we trained, this is just our algorithm for recessed distension, if we train on males only, it doesn't work well in females. If you train on females only, it doesn't work on males. And if you train on male and females equally, it works equally well on males and females. And I just showed you the reason why. Because AI, so machine learning, is very, very good at detecting patterns. And in this case, it detected fat distribution and tissue. There are subtle differences between males and females. How females deposit fat and how males deposit fat, we all have fat in our muscles, is different. And so that's what it detected. So that's why you have to be very careful with all of your algorithms. This is just a very obvious example, but you can have very subtle differences. For instance, if you purchase an algorithm, an AI algorithm here in India, but it's a US product, you must ask where the data was trained. Because most available data today on the planet is from North America and China. So you need to make sure that the product you buy here is generalizable to the Indian population. And so that's another thing we're doing in Costa Rica, for instance, in the breast cancer detection. We're retraining the algorithm in Costa Rica using Costa Rican data for exactly that reason. Last thing, this is just a plug for you guys because I see it all the time. Traumatic brain injury or concussions is absolutely a thing in India. It's twice the rate that it is in Canada for us because you don't wear your helmets. So the reason I'm bringing this up is this is just another example of what we're doing. It's called mybrain.care, and I do a lot of work in traumatic brain injury. And I just wanted to show you how you can take AI at a very simple level. So this is our website that we just literally put together. And I'm not going to go into detail just for time. But you start something small and you move to something larger. So first it's just going to be a social network. It's going to be, patients can join a social network. They can learn about, traumatic brain injury. And then we're going to develop what we call a neural reserve, which is, so there's a perfect example of data science. So we're going to, through data, we're going to be able to provide feedback to patients who are recovering, so rehab, as to where they are in their recovery, right? Are they pushing too hard or are they not doing enough, right? So that's data science, and that's a prospective trial or a study that we're doing where we have to collect all the data and then we're turn it into AI. But there's another example of how you can bring something very impactful in the clinical space and bring it right to your phone, okay, using AI. It's just an example. And that is it. Thank you very much.